that probably is good to hear a couple times. So hopefully the redundancy will be just reinforcement. I'm going to talk about the full spectrum of heart failure progression, talk about management, referral, and treatment strategies for the advanced heart failure patients. And I'll start by talking about just modern management of heart failure, because I think this is one of the greatest kind of variable practices that I see in the patients that are referred to me, and would love to get kind of everyone caught up to speed on what we consider sort of the most cutting edge practices in heart failure. So I'll just talk about kind of the most recent medications that have really hit the scene, and then talk a little bit more about CardioMEMS, which I think really kind of sits alongside these other treatments as far as important therapies for our advanced heart failure patients, or patients who are getting advanced. I'll talk about Entresto. You guys all know about the original trial that was published back in 2014 that showed the benefit over ACE inhibitors. So good benefit across the board from both heart failure hospitalizations as well as death. I think, and as a result of that, it's a class 1 indication now to be used. And I think important to note that for the vast majority of our patients now, we're no longer trialing them on an ACE or an ARB before starting Entresto on them. In the vast majority, we are just going straight to Entresto. And as long as the blood pressure can tolerate it, we are usually very successful with that with minimal issues. I do want to pause to talk a little bit more about the use of Entresto in the HFpEF population, just because I still think it's relatively underutilized. This is the trial, the landmark trial that was published on it, which is the Paragon trial. Important to note that this was a negative trial. So the primary endpoint, which was combined heart failure deaths and hospitalizations, they did not meet their primary endpoint. So as a result, they had to basically kind of declare this negative, and there was a lot of disappointment about that initially. I do think it's worth pointing out that when you take a look at the significance of their outcome, the p-value was 0.06. We all know that our positive cutoff is 0.05. So they came really close to crossing that confidence interval threshold. I'm sure the study was powered appropriately, but maybe an extension of the trial could have potentially yielded a more positive result. Who's to say? But I think we can say that there are some populations who do seem to have a benefit from it if you take a look at the subgroup analysis. So that's female patients in particular seem to have a much larger benefit compared to the male patients. And then in particular, those patients who had an EF that was lower than the median for the trial, which was 57%, they tended to have a benefit more so than the patients who had a very normal EF of greater than 57%. And because the cutoff in this case was 40% for the EF, you're capturing a lot of patients who do have a reduced EF, but kind of a mildly reduced between 40 to 50%. Because of that signal towards being positive, there has been a number of kind of post hoc analyses done with this, where they took a look at a combined data pool that took all of the Paradigm patients from the HFrEF trial and all the Paragon patients and said, it's not really a drug that is good in one indication, not good in the other, but there's like a spectrum of benefit. So if you take a look at the left, you can see that if you combine all the data, the spectrum would benefit anybody that's under that yellow line. And you can see that that yellow line goes out pretty far. I mean, past 60% EF, as far as patients who would likely have a risk-based benefit for supraventricular valve. And then that effect is also impacted by gender and EF as well. But the bottom line is there still may be a group that benefits from this. Because of the sort of post hoc analyses that were done, the FDA took a look at all of the data together and basically said, this actually is an okay drug to be used for HFpEF. And they decided that a couple of years ago, which I think may be surprising to some people because we still don't really use a lot of Entresto in HFpEF, but technically it is approved for it. Of note, just some inside baseball, there's like this advisory committee that takes a look at all the data, and they couldn't decide on whether the upper limit should be 55 or 57% based on the trial. So basically said, it's your decision. You decide who gets the benefit and what the EF cutoff should be based on your own practice. So really kind of the sky is the limit as far as how you want to use Entresto with different HFpEF patients, but probably beneficial more for those patients who have a slightly reduced one. I also want to talk about SGLT2 inhibitors. Hopefully, this has really been incorporated into your practice at this point. There was some hesitancy, leading into, I think, the last couple of years with utilizing these therapies, but hopefully a lot's been mitigated now, just, as people see the benefit related to it and know that, relatively speaking, it is a very mild side effect profile. It's indicated for patients whose EFs are less than 40%. Well, that was the initial data that came out, though now we know that empagliflozin in particular is also indicated for greater than 40%. Neurocarditis, so you need to have some symptoms, and you can really use this on top of any GDMT. Also indicated for the two major drugs, empagliflozin and dapagliflozin in both diabetes and CKD as well. Some of the nice benefits are it has a minimal impact on blood pressure. It might have an initial bump in your creatinine, though that usually gets better after a few weeks. It might impact your need for a loop diuretic because of the diuretic effect of the drug. There are a risk of genitourinary infections, in particular yeast infections, as well as UTIs, and then in some rare cases, Fournier's gangrene as well. You do want to be careful using this if a patient's on insulin already, because that may decrease their insulin dosing. But what I would say to that is I would not wait to get approval for an endocrinologist or from like a nephrologist before starting this drug. If you feel confident that the patient will benefit from it, you can start it. And then if there's any issues down the line, we can work it out. But I wouldn't, we had a lot of hesitancy at first to start this without kind of corroborating with other teams, but I think it best practice is just to go ahead and start it. This is a table summarizing the majority of the data that we have for this population. You can see that 5 drugs have been studied, but if you take a look at the third column there, for those patients with and without diabetes, the landmark trials have been EMPA reduced, as well as DAPA-HF for EMPA and DAPA. Both are effective, and then both are also beneficial in diabetes and kidney disease as well. This is the Emperor Preserve trial, which kind of extended the indication of the SGLT2 inhibitors and really broke new ground, because up until this point, even though there are other drugs that we had used, like Entresto, like I just mentioned, and spironolactone in the HFpEF population, this was the first trial that was actually positive for that population. So technically speaking, the only positive HFpEF trial that we have on record, period. So you can see that the hazard ratio was beneficial for empagliflozin there, and this is at preventing hospitalizations and death. And then dapagliflozin came along as well with the DAPA trial, and then also demonstrated benefit in this population as well. So both of these drugs can be used. EMPA came out first, so has that initial FDA recommendation, but DAPA is going to follow shortly behind. So to that end, because of this data, we know that there's a class 1 indication for using these drugs in HFrEF, but also specifically for both HFpEF as well as HFMREF, which is mildly reduced EF. That's at 40 to 50% population. There's a class 2A indication as well. So really the only drugs that were able to attain that level of recommendation for HFpEF population. I get asked about vericiguat sometimes. This is, I think, a reasonably good drug in patients who are already on all of the maximally tolerated GDMT, because the data is not as strong for vericiguat and the next drug, avabradine, as they are for the other 4 pillars of heart failure treatment. I would really make sure those are maxed out before reaching for either of these. The nice thing about vericiguat is that in the Victoria trial, the EF cutoff was 45%. So you do capture that population of 40 to 45% that would otherwise not necessarily have guideline-directed recommendations. The mechanism is it's a soluble guanyl cyclase stimulator, which is kind of a unique target when it comes to heart failure treatment. But it produces some of the same effects like vasodilation and smooth muscle relaxation. It can cause some hypotension and anemia. It also can be quite expensive and difficult to obtain for patients, though, usually with prior auths and things, you can get that worked out. And then this is just the mechanism of how vericiguat works in the endothelium. The trial was a positive trial, which you wouldn't necessarily know because nobody ever really talks about this drug very much, but it did meet the primary endpoint of both reducing heart failure hospitalizations and death. I think the reason that it didn't make as much of a stir as SGLT2s is that the death benefit was not really there in the trial. It was primarily driven by heart failure hospitalizations. We already have 4 other drugs that we can use that have a mortality benefit as well. So maybe just kind of 5th line medication for that population. Patients who are older, have renal dysfunction, or have a normal EF might not benefit as much. I also get asked about avabradine. This is one that I don't typically use as much. And part of the reason is that really this is a drug that is, I think, best suited for patients who have a maximally tolerated beta blocker. So that's specifically either 200 milligrams of metoprolol or 25 BID of Coreg. I don't have a ton of patients who are able to reach those maximal doses. So if you can't reach those maximal doses, I probably wouldn't reach for avabradine because the main limitation for that is usually heart rate, and you should only use this drug in patients whose heart rates are greater than 70. The EF cutoff is 35% for this one. It's a funny channel blocker. So it can also be used for inappropriate sinus tach as well. It can cause bradycardia as well as hypertension. And it can also potentially increase the risk of AFib. So if you have RVR to begin with, probably not the drug for you, and contraindicated in pregnancy. This was the SHIFT trial. This is 12-year-old data, but basically demonstrated a significant benefit as far as reducing heart failure hospitalizations, but not mortality. So this is the, because of all the new drugs that have hit the market, there had to be a new consensus statement put out a couple of years ago that showed that, when it comes to symptomatic heart failure, you really want to be using all of the tools that are at your disposal. So it's really no longer a stepwise progression the way that we typically thought about it. It's really kind of an all hands on deck, try to get everything on board as soon as possible, including during the index hospitalization. I think to better illustrate that, I have this diagram here. On the left is kind of typically for many decades how we started heart failure treatments. You start one drug, see how they do, start another, see how they do, and keep moving forward. I think we have a better schema here, which is that, again, you start up front with the ones that are going to cause the least amount of harm in the short term, especially on the renal function. So that's the beta blocker and the SGLT2 inhibitors. Really good safety profiles, especially for those patients who are admitted, who are not decompensated. You can easily start these and get that benefit right up front. And then eventually you can add on the ARNI, and this should all be done within a couple of weeks, if at all possible. Which is the Entresto, and then eventually the spironolactone as long as the renal function is stable. This is not really a hierarchy. All four of these medications are really beneficial. So the best outcome is that they end up on some doses of all four of these. I just want to make a point here. I don't have a slide on this, but there was a trial recently that demonstrated that Entresto does not necessarily have as strong of a dose-dependent benefit as some of the other drugs, in particular the beta blockers. So if you have a patient where you're deciding, should I go up on the metoprolol, Coreg, or the Entresto, especially if there's any blood pressure issues, it's better probably to go up on the beta blocker, because we know that there's a really strong dose-dependent benefit with beta blockers, and that the maximum benefit is when you go from the second highest dose to the highest dose. So from going from 100 to 200 of metoprolol, or 12.5 to 25 of Coreg, that's where you get the most bang for your buck. So I would really try to hit those doses if you can, even if it means they end up on 24, 26 of Entresto. Moving on to cardiomems, I want to just highlight this because we really, I think, don't utilize this enough. It's got really strong data behind it. I think in part because, that it's kind of laborious to follow some of the data at times, and then also because it's, I think, until recently been hard to find anyone to actually implant this device at Prairie. I think it's not been used as much, but I do want to highlight it because we use it a lot up at UFC, and it's been tremendously beneficial. It's a pulmonary artery pressure guided system that you can monitor remotely. Patients during a right heart cath have a little sensor that's shaped like a butterfly dropped into their inferior left pulmonary artery, and then that is able to measure their pulmonary artery pressures, and in particular pulmonary diastolic pressures, anytime they put up this special pillow up to their chest. And then based on that, they're able to follow their filling pressures and monitor diuretics appropriately. And you can see that on the initial trial that was done back in the 20-teens with the Champion trial, there did demonstrate a significant benefit as far as heart failure hospitalizations, as well as a reduction in death as well. That was in a relatively small population that was studied. They did a much larger study because when they initially did this trial, it was kind of for more advanced patients, and they opened it up to class 2 patients as well to just try to extend the group that would perceivably be benefiting from this. So they enrolled the patients from 2018 to 2019, but then the follow-up extended through 2021. And what happened was that during COVID, everything kind of went to hell, and patients were not coming into the hospital when they were supposed to, and there were a lot of issues as far as the messiness of the data afterwards. So what they had to do kind of afterwards to sort of clean up the data was point towards what happened to the patients before COVID started and kind of hone in on that data. And when they did that, they showed that, in fact, the heart failure hospitalizations, which was basically even in the overall population, in the pre-COVID analysis was a positive result. And then also it reduced heart failure events significantly, and also the combined endpoint. So they had to massage the data a little bit, which is why it's not quite as revered of a study as some of the other data that's come out about heart failure treatments, but I think still a really great tool. And I can just say anecdotally, it's probably, for my frequent flyers who have gotten this, it's been able to keep them out of the hospital for much longer than we had even anticipated. And just to follow up on that, so that was like the initial trial, and then a couple of groups have taken a look at a systematic review and meta-analysis where they combine all of the different trials that have taken a look at remote monitoring. The majority of those patients were made up by the initial champion data as well as the GUIDE-HF trial that I just mentioned. And they found that when you combine all the data, there is a significant reduction in heart failure hospitalizations. And of note, that's regardless of EF. So this is as beneficial for a HEF population as it is for a HEF-REF. And then if you take a look at all-cause heart failure, combined endpoint of heart failure hospitalizations and all-cause mortality, there was a benefit there as well. So really, I mean, falling in league with a lot of the therapies that we give, like SGLT2 inhibitors, this kind of should sit alongside that as far as a mainstay of therapy. So I think one of the focuses of the talk is intended to be when to refer to a heart failure specialist. So I'll spend the majority of my time talking about that because that is probably the number one question that I get asked is like, who do you want to see? Like what patients do you actually want to come to your clinic? Do you want like the stable young heart failure patients whose EF is 10%? Do you want like the end stage patient who's like 82 years old and has 100 comorbidities? Would they be a good candidate? And anything in between. So just kind of want to hone in on what are the key features that I would say are crucial towards, kind of getting good outcomes out of a heart failure specialized clinic that's intended towards kind of getting people down the path towards advanced options if they need it. A lot of this will be dependent or based on a consensus document that was produced by the ACC a few years ago. There's a lot of different triggers that are identified, so I'm going to break these down one by one. So this is a broad one, and this is probably, a scenario where, we could get a little bit too overloaded if we saw every single new heart failure patients. But I really mean it when I say that I'm happy to see any heart failure patient, regardless of their etiology, how long they've been treated for, et cetera. And the reason I say that is because I feel like those patients, there's always something additional to learn from them. And not just in their management, because I think typically speaking, the Prairie referrals I've gotten have been really optimally managed up to that point. But, as far as additional diagnostics, because I think it's rare that a heart failure patient should have their book completely closed on their etiology if we don't have a good diagnosis in place. I also just want to point out that part of the reason I think it's so important to make sure that heart failure is treated optimally is because so many heart failure patients are not even being treated by a cardiologist, let alone a heart failure cardiologist. So this was a study of 13,000 patients that were looked at respectively in the US, and it showed that of patients who were diagnosed with heart failure, only 55% of them even had a cardiologist, and there were even longer wait times for referral if they were older, women, or at lower socioeconomic status. So I'm really kind of being mindful of which patients hopefully are being referred to us, and just encouraging, for you guys, dealing with, PCPs and so forth, to make sure that we get those patients in as soon as possible. Patients who have high risk features, there's a lot here, so I'm going to break these down one by one as well. Anyone who needs chronic IV inotropes, obviously, if you have a dobutamine or meronome patient, they should be evaluated by an advanced heart failure specialist. Patients who are on those therapies have a terrible outcome. You can see this is their cumulative survival. Look at what their survival is just at 12 months. I mean, we're talking less than 10% of patients who are on chronic dobutamine or meronome. And so typically, if we say what is afterlife expectancy, we say less than 6 months, because that's I think the realistic outcome. Now, we've had some really great success stories. I had a guy who was following at the Prairie Clinic for 3.5 years who did great with his meronome over that time, but he was a total outlier. Many of our patients do not make it even past a few months. And this is just further data that supports, it pulls together a number of different trials and demonstrates how bad the mortality is at 6 months. Typically speaking, we're talking greater than 60% if you take a look at any of the independent trials that have looked at this. This is true for even patients who are in the hospital getting meronome for a short term. So this is a population I see a lot, but maybe not even as much as I should, which is that patient who comes in, people start them on dobutamine for a couple of days, they don't get hemodynamics, they stop the dobutamine because they say the patient's better, and then send them home. These patients have a horrible outcome compared to their relative peers, almost as bad as those patients who are on chronic therapy. You can see that the risk of death or readmission in that population is 35% within 60 days. So you can expect 1/3 of those patients who are on those therapies to expire in a 2-month period. And just as a side note, this is kind of newer data. This was the DOREMI trial. Sometimes I get asked, should we start dobutamine or meronome? What's the difference between them? This was a study actually had the the wherewithal to go ahead and randomize them, which I thought was pretty brave. And they actually showed that there was really no significant difference between the two as far as in-hospital death, need for CPR, strokes, any negative outcome that could potentially occur. They were all pretty much equal between the two populations. All right, how about clinical deterioration? So these are the markers that I think you guys are probably pretty attuned to as well. So these are patients where their edema is just getting worse, not really responsive to diuretics. Their BNP is climbing off the charts. You guys may not do, exercise testing often, but, if they have any decrease in their exercise tolerance in general, if they get a right heart cath and they show that they're decompensated, or if they have any worsening ejection fraction or LV dilation. Always, when you're taking a look at that echo, the EF is important, but always scroll down to that LV IDD as well, because that's a really nice marker that tells us what is the likelihood of this patient being able to actually remodel and improve their heart function over time. If their EF is greater than 6.5, the likelihood of them substantially remodeling is probably not very high. They're probably too blown out, too scarred off, and not really going to be able to recover. BNP is important. I check BNP serially as an outpatient, just as a marker of how well the patient is improving with diuresis and GDMT, but also as a marker of how much they may be progressing from a heart failure perspective, and it has a relatively good long-term prognostic value. Patients who are persistent class 3-4 symptoms and who have really significant congestion or fatigue in spite of any GDMT that they may be on, a good population to send over. Patients who are just not improving the way that they should be. There was a Swedish heart failure registry that took a look at 10,000 patients, all based out of Sweden, with advanced heart failure. And if you do have these advanced symptoms, the observed one-year survival was only 76% compared to 95% expected. So just the symptoms alone, regardless of whether they need inotropes or hospitalized, et cetera, portends a pretty poor prognosis. 1/4 of those patients dead at 1 year. 2 or more ED visits or heart failure hospitalizations. Now, this is what's recommended in the guidelines here by the ACC in the prior 12 months. But I would really say that actually, if you're reaching that point, that they're actually like a frequent flyer, that's probably past the point that they should be considered for a referral. I say that because there's an overwhelming body of evidence that has demonstrated that even one heart failure hospitalization portends a really poor outcome. So this was a trial. It's a little bit older, but it showed that within 1 year of someone's admission for heart failure, 37% of males and 30% of females had died. So really poor prognosis. And this is totally independent of whether they needed advanced, if they needed inotropes or anything more advanced during the hospitalization. You just come in, you get diuresed, you leave the hospital, 1/3 likelihood of being, of expiring within 1 year. And then if you take a look at the end of follow-up, which is 3 years, they also showed that 72% and 66% of women had mortality. So again, just to highlight that point, if you have a patient now within 1 year, one of them will, if you have 3 patients in the hospital right now, at 1 year, one of them will be dead, and at 4 years, 2 of them will be dead. So another strong indication is for those really symptomatic hypotension patients, especially when the systolics are chronically hanging out below 90. Usually the issue there is that you're trying to up-titrate their GDMT and they're not really tolerating it. Particularly poor prognosis for those patients where they may be on a certain level of GDMT, and because of their blood pressure, you're having to peel back on it. That may be a patient who's already in ambulatory shock and should really be referred sooner rather than later. Hypotension during an acute heart failure hospitalization is strongly associated with 30-day mortality, and has nearly double the hazard ratio for death compared to those patients who are not hypotensive during their initial heart failure hospitalization. Again, this is based on the guidelines where they say, okay, if a patient has really bad renal disease, they should also be referred. I would really strongly make the argument that this is too late for the patient to be referred to us. The reason I say that in large part is because if somebody comes to us with a creatinine of 1.8 or 2 or 2.4 with end-stage heart failure, the amount of options that is available to them is much more limited. With an LVAD, we can do an LVAD with a patient with a creatinine greater than 2. But what we always advise those patients is that they have a fairly high likelihood that with that baseline renal status and after the complications of the surgery, that they may end up on dialysis afterwards. And in a lot of cases, that dialysis is temporary. We've had many success stories where patients needed dialysis for a few weeks and they were able to come off either as inpatient or outpatient. But we don't want to reach that point. There's no reason why anybody should have to get dialysis after any kind of cardiac surgery if they're being referred appropriately in a timely manner. Same goes for heart transplant. If your creatinine is 1.8, even if you have normal renal function, making good urine, clearing all your metabolites, etc., you're still going to need a heart kidney transplant, because after we do the kidney transplant, or after we do the heart transplant, you're inevitably going to have worsening AKI, both from the transplant as well as with the immunosuppression medicines we give, like tacrolimus. So your kidney function is only going to worsen after the transplant rather than improve. So typically we say that those patients should get a kidney up front. So if you're waiting to the point that the creatinine is this high, you've bought them another organ that they wouldn't have needed otherwise. If you take a look at any of the different heart failure scores, you can see that BUN and creatinine are pretty much present in all of them as a major risk factor for worsening heart failure prognosis. Anybody who comes in with new onset AFib or VT-VF, anybody who comes in with ICD shocks, this is a patient where probably the arrhythmia is a signal of their worsening impending heart failure decline, and really should be considered for referral at that point. There's a number of risk models that we use personally that can predict different outcomes. The ones that we use most often are the Seattle heart failure model and the heart failure survival score. If they do poorly, if you have 10 minutes to kill and want to put in all these variables in, you can do so for the heart failure patients. We don't really do this outside of a patient that we're considering for surgery. In particular, if they need like a kidney or liver transplant, we'll sometimes utilize this data. But if they're doing worse on this, then that would also be an indication to refer. So this is a nice mnemonic to help people remember, all the different features that are, typically for us red flags as far as needing a heart failure specialist. So I need help. I is IV inotropes. N is New York Heart Association class 3B or 4, or elevated BNP. The first E is end organ dysfunction. So again, AKI, worsening liver function, etc. If their EF is less than 35%, if they have D, defibrillator shocks, more than one hospitalization, or even just a single one. E is for edema despite escalating diuretics. L is low blood pressure, which can correspond with a high heart rate, as well as P, prognostic medications, meaning that they're either not tolerating it or you're having to go down on the GDMT in response to different blood pressure issues. So if you need any help, switching patients over from ASARBs to ARNIs, I don't think this is really an issue for anybody here in this group. But if they have chronic renal disease and you're unsure about what therapies patients should be able to be getting due to hyperkalemia, et cetera, that's also a consideration. To the hyperkalemia point, a lot of times our patients will develop it once we've started them on both Entresto and spironolactone. But for the patient who is clearly benefiting from the GDMT, we would actually recommend giving them medications to lower their potassium, things like Veltassa, rather than actually stopping the spironolactone if we think that they really need it from the symptomatic as well as mortality benefit. These are the starting doses for all these drugs. You guys are all familiar with this. I just mentioned this to highlight that really the purpose of these medicines is not just to start some dose of the medicines and call it a day. You really want to push these medicines as far as they'll go. And what I always tell the patient is you really want them to be on the dose that is one dose shy of making them either hypotensive or lightheaded or dizzy or having any other kind of negative side effects related to it. You want to reach that point and then back off a little bit just to confirm to yourself that you are actually optimally on the highest doses that you can be with all of these drugs. That's true for the beta blockers and ARNIs as well as aldosterone antagonists as well. The reason that I highlight this is because all of the data that we have at our disposal shows us that we're not really good at actually getting people to the doses that they need to be on. So the green here are the patients who are on what we would consider a pretty, or who are on the drug period. And then the red is the patients who are not on it or in spite of having no contraindications. So this is a little bit older. I imagine the ARNI data is better now, but ARNI is still not utilized to the extent that it needs to be in this population. That's even true of beta blockers and spironolactone as well. I've really seen this in particular with spironolactone. There's just something with spironolactone where people seem really hesitant to start it, I think because of the renal and potassium issues. So I just, if those happen, they're reversible. I mean, if they have an AKI, if they have hyperkalemia, that will be, mitigated once you stop the drug. So if you have any concerns, just go ahead and give it a try. Check their labs within a week, and if there's any issues, you can back off if you need to. I'm also a big fan of utilizing a half dose spironolactone if you need it, to 12.5 milligrams. I think better to have that on board than nothing at all. This is another diagram that shows all the patients who are on the drug, but not on the optimal doses of it. So you can see the red are the patients who are on less than 50% of the optimal dose of it. And then the gray are the people who are 50 to 100%. And then the blue are the success degrees. And you can see that aside from spironolactone, everyone is not doing as well as they could be. Of course, this is patient dependent based on blood pressure and heart rate. But overall, I think we're not achieving the kind of optimization that we need to in this population. Spironolactone just stands out because I think everyone's used to starting it at 25 milligrams and then keeping them at 25. So a lot easier to optimize than, say the RNAs or the beta blockers. So you mentioned EF less than 35% who really are not improving in spite of GDMT for over 3 months. And if you want any kind of imaging or evaluation or anything else before you put in the ICD, that would be the kind of window to do it, especially if you think, oh, they might want to do a biopsy and the device might get in the way of that, or if they might want to do a cardiac MRI or any other advanced testing, you can plan for that. If you just need a second opinion where you're not really sure what the cause of the heart failure is, maybe your ischemic evaluation has been inadequate, you're worried about inflammatory cardiomyopathies or any more unusual cardiomyopathies, would be happy to see that patient to kind of get a better sense of what their overall diagnosis is to help with prognosis. For the ischemic etiologies, we have a number of advanced imaging modalities that we can use. I think probably you guys have most of these available to you as well. Cardiac PET is one that I utilize often. I'm actually a cardiac sarcoid specialist, so I use a lot of cardiac PET scanning. And we're creating software that will be able to utilize cardiac MRI and PET at the same time so that we can get the best quality images for that population. We're worried about sarcoid or their inflammatory cardiomyopathies. We also do biopsies day in and day out for our transplant patients, so we're very comfortable doing it to look for any native heart disease as well. More unusual diagnoses all listed here. We have, like I said, a lot of imaging modalities. You guys have PYP and I think are doing a relatively good job at getting that on board. But also just being mindful that genetic testing is a really important part of the diagnostic algorithm for those patients, especially if they have a strong family history. But even if they don't, I think still having a genetic test to help confirm that there just hasn't been something missed as far as gathering the family history, or whether they have a de novo mutation, we can figure all that out with the genetic test. And then for valvular disease, kind of more advanced things that we can do, but that I'm sure Prairie is excellent at doing as well. There's patients who don't need to be followed every 3 months with a lot of adjustments to medications. There's those that just need to be seen once a year to make sure that everything's in line, not just as far as their therapies, but as far as any other additional diagnostics that need to be done, and maybe just capture them at a certain point in the trajectory before they crash to make sure that they are getting good support, good therapies, and if they are seeming like they're headed downhill, we can help intervene by doing any advanced options consideration at that point. And we also have a number of clinical trials that we can enroll patients. So just to summarize kind of the group of patients that we'd be most interested in seeing in the heart failure clinic. So these are patients who are significantly symptomatic, who are hypotensive, have renal failure or new arrhythmias. Patients who are hospitalized, again, not just frequent flyers, but even those first-time hospitalizations. And anyone who has a new diagnosis where you're not really sure what's going on with the patient and you kind of smell something off about the patient's course. Maybe they're a younger patient without a really good explanation for why they have it. Would love to see those patients just to get a little bit more of that workup complete. All right, so I talked a lot about the patients who should be referred to heart failure, but what will we actually do once we see them? So one of the things that we can do is manage specialty diseases. So I mentioned that I'm a cardiac sarcoid specialist. I do a lot of PET scanning. We do a lot of management with regards to the immunosuppression that the patients need. There's a big overlap with immunosuppression that we utilize in our transplant population. So really easily able to manage a lot of those side effects and getting the medicine to the patient. We're also specialists in cardiac amyloid as well. I have a pretty decent sized amyloid population that I'm treating down in Springfield now. We watch out for different red flag symptoms, things like carpal tunnel, a lot of orthostatic symptoms or GI issues. We're able to help differentiate the different kinds of amyloid, the AL amyloid, which is more rare, versus the more common TTR amyloid, which generally has a better prognosis, versus the much more rare forms of amyloid, such as AA. We're able to also help distinguish between the familial and senile patients as well with genetic testing. We have an algorithm in place where we take a look at PYP scanning, as well as any lab work, any cardiac MRI that must be done to help identify, kind of hone in on what form of amyloid the patient has. And then that can help us determine whether we want to start therapies or not. This is the PYP scanning. Again, you guys do plenty of this here, so I don't think I need to emphasize this too much, but maybe for those nurses who are not referring a lot of patients for PYP scanning, just being really mindful of those patients who have, thick, kind of concentric hypertrophy on their echoes, who have a lot of bad diastolic dysfunction. There's a Mickey Mouse sign where like the atria and the patient are huge, all things to watch out for and suspect amyloid. If you do suspect it, send them for this PYP test where they can look to see if there's any cardiac amyloid deposits in the heart. It's very sensitive for detecting specifically TTR amyloid. So a really useful tool and first line and evaluation for cardiac amyloid specifically. What do we do once we have that? Well, there's a ton of new medicines that are coming down the pike. The most mature one is this tafamidis that inhibits TTR dissociation and improves cardiac amyloid in particular. That's based on the ATTRACT trial. I'll talk about that in a second. There's several new medications that are coming through as well. There's patisiran, but then there's also a sister medicine called vutrisiran and Vutra, which is given once every 3 months or so. This is a medication that we have pretty good experience with at University of Chicago. I don't think, based on my discussions, I don't think there's a single patient in downstate Illinois who's on this drug. And there really needs to be, because there's probably a largely unrecognized amyloid population in the area, especially as the population ages downstate. So I think we need to be more mindful about finding those patients and then making sure they get on the right therapies. This is the ATTRACT trial that I mentioned for tafamidis. It was a multi-center randomized placebo-controlled double-blinded trial, 441 patients, which is really hard in an amyloid trial because amyloid is a pretty rare disease. So to find 400 patients who they could randomize was pretty good. And I mentioned this because there's an actual mortality benefit with tafamidis. I mean, we don't have a lot of medications in our lives that we can use that produce a significant mortality benefit. We have the GDMT, of course, but for a HFpEF population, there's really nothing. So to be able to see a drug that helps this subset of patients actually live longer is really exciting. So we hope to get more patients on that if we can. And then I mentioned vutrisiran as well, which is now emerging in the market too. I mentioned this slide because I think I have a subset of patients that I've asked people to refer to me. But then not all of those patients necessarily need advanced options. I think you guys recognize that, only a relative small proportion of those patients ever get to transplant or VAD. Here are the features that we're actually looking out for patients who need it. So a lot of the times, the first step that I'll make when I get a new patient in my clinic is I'll do a right heart cath. And specifically, I'm looking at the FIC cardiac index and seeing whether it's in a shock range of less than 2.2. If the patient is less than 2.2, they may require inotropes, or maybe the patient comes to me already on inotropes. And if they are, they're truly a stage D end-stage heart failure patient, and the patient needs to be considered. Additionally, those are not the only patients, inotrope-dependent patients, that should be considered as well. We also do plenty of cardiopulmonary stress testing. I'm very fortunate at Prairie to be able to have colleagues who perform the tests and get the results to me, to be able to use this for overall prognosis too. So when we do this, the two key numbers that we're looking at, we look at the entirety of the results, but we really hone in on the peak VO2 oxygen consumption. If it's less than 14 or less than 50% predicted, it's a very poor prognostic indicator that will usually, for us, prompt a right heart cath and then potentially transfer for advanced options. If they also have an elevated VEV-CO2 minute ventilation of greater than 35, also a very high risk feature independently of the peak VO2 as well. So these are the actual numbers that we really look at and care about when it comes to transplant or LVAD. It's a little bit esoteric, which is why I'd love to see a wide swath of patients and be able to hone in on which ones are eventually going to meet this criteria. The first consideration, when we see somebody is heart transplant, but depending on, what kind of comorbidities they may have based on age or weight or other, disease states they may have, we may reach for an LVAD. I just want to briefly talk about this. This is the HeartMate 3, the only current LVAD that we use. Based on the Momentum 3 data, we know that it's probably the best pump. Well, it's the only pump on the market, but it was the best pump that we've ever created. It was really specifically designed to reduce the incidence of all of the bad side effects that you sometimes see with an LVAD. In particular, the pump clotting off, which was a real big issue with the prior generation of pumps, the HeartMate 2. They put more space between the rotor and the casing so that you wouldn't create as much friction, which causes heat, which causes clot. And then also there's it's fully magnetically levitated, and they built in this kind of fake pulse to also help reduce any damage to any of the blood cells as well. We know that based on the full report of the data, those patients who had the HeartMate 3 just generally did better as far as all of the different outcomes, whether it's thrombosis, strokes, bleeding, or GI bleeding. And if you take a look at the 5-year data, which just came out last year, you can see that there was a really good survival of 58% in 5 years. So for the first time ever, we were able to say that the life expectancy on an LVAD is greater than 5 years. We'd always used 5 years as kind of that benchmark. And I think that's really helpful for patients to conceive of, okay, so there's at least a 50% chance that I'll make it to 5 years on this, compared to what we had before, with HeartMate 2, where it was less than 50%. And of course, a very dramatic difference compared to those patients who are on inotropes or need inotropes and don't get them. They have equal mortality of less than 6 months compared to these 5 years. Okay, so I talked a lot about that. I just want to highlight that I have my clinic that I go to every couple of weeks down in Springfield. It's on the first floor of Prairie Heart. I sit alongside Dr. Morty. I work really closely with some colleagues there, including MA Judy. And I think I saw Anne on the call. Hi, Anne. I've worked with her in the past too. I was just there yesterday. I had a full day clinic. I usually see about 14 patients in that clinic. I was up to 18 yesterday, so I ended up coming at 8 a.m. and did an all-day clinic. That's my cell phone number. If any of you want to take it down, I'm very happy to just get a direct referral on my cell phone. I have full access to the Prairie EMR, so I can look up any patient based on the MR number or et cetera, and then get them plugged into the system. Gail Shear also does most of the intake for other patients, so getting referrals to her is helpful as well. As far as the success of the program, so we've been doing this for about 4.5 years now. We've had 14 heart transplants as a result of this, including one this year. We've done a triple transplant, and he's doing very well. He continues to live in the Springfield area. And we've done a heart kidney transplant as well, so good multi-organ success. And we've done 14 LVADs as well, including 2 this year. So really robust program, and we're really excited to see it grow and continue to follow those patients kind of in a hybrid format between both Springfield and University of Chicago. This is a little outdated at this point. In 2022, we actually did 66 transplants. We did 61 the year before. 66 was the most that any program in the state of Illinois had done in history. So that was a real feather in our cap that we're very proud of. And then on the most recent, looking at the data of outcomes, we had 100% 1-year survival. This is just kind of really the gold benchmark that you want to reach for as a transplant program, is to make sure that every single one of your patient makes it. You get flagged when it drops below 85%, so we've really exceeded that amount. And we're the only large volume center in the country that can actually claim to have done this. So very proud of that. We also do a lot of research in LVAD as well as heart transplant as well. These are just some of the papers that we published. All right, sorry to have to end on just bragging about University of Chicago, but I'm happy to answer any questions. I really did want to leave plenty of time for any Q&A that people have.
I do have a question, Dr. Chung. You mentioned the LVIDD, I think is what you said on the echo. I don't know that I've ever heard of that or looked at it.
Sure. So, when I put it in my report, we talk about the left ventricular end diastolic dimension, but where it is in the echo report is, if you take a look, there's the full report, and then there, at the bottom, there's like 50 numbers, right, that are measured by the echocardiographer. So that it'll say IDD or LVIDD, and that's the internal diastolic dimension. And that's when we talk about the LV size, or if the report says, oh, the LV is mildly dilated or severely dilated, it's all based on that LVIDD. That's the measurement of it. So that's one that I always record and note in my note. And again, an important signal, I think, for how the patient's going to do over the long term.
And what are we looking at specifically when we look at that number? So
we're looking to see if the patient is significantly dilated. So there's a couple of different factors to consider. So if it's 5 or less, that's normal. And actually 5 or less portends a relatively poor prognosis, for example, from an LVAD, because the chamber is too small. So if that chamber is that small, it's a patient who, even if they have a reduced EF, probably has a relatively good chance of being able to remodel. They actually have not significantly negatively remodeled over the course of their heart failure, especially if it's been in the short term. So, you get a new diagnosis, but the LVED is 4.8. Well, that patient is much more likely to be able to recover to a normal EF than a patient whose LVEDD is like 7 to begin with. And then on the other end of the spectrum, those patients whose LVEDDs are 6.5 or greater, we almost never see those normalize after they've dilated that much, just because of the remodeling and the negative, the stretch on the myocardial fibrils. So they don't really ever get back to normal. Does that answer your question? I don't know if there were any other.
Yeah, it definitely does. Thank you for that. Does anybody else have any other questions? Okay. Well, I know you have another meeting to go to. Very busy guy. So we really appreciate you coming and talking to our nurses and facilitators and NPs and PAs. If you guys have any questions, definitely reach out to Dr. Chung. He's always happy to help. And like you said, his phone number is on there and his email. He's pretty responsive in my experience. So Gail can also get patients scheduled, like you said, here at Prairie. And then if you have any questions, you can, like I said, reach out to him. So PERC will send you the evaluation for this and you'll get your CME for that. And then if you have any issues, definitely reach out to Crystal or Cindy over at PERC. Okay, thank you guys. Have a great day. Thank you again, Dr. Chung. Hey, can you email me your PowerPoint slide when you get a minute?
Oh, yeah, we'll do.
Okay, thanks again.
Thanks.
Now, so it was dinging me.
I don't know how to end it.
I saw you pop in.